Hey everybody, David Marcarian here, inventor of the MyoVision. I'm here with a very, very famous guy, and a very funny guy, Dr. Gregg Friedman, who's a documentation expert out of Phoenix, Arizona, and also an expert on the MyoVision. He's going to tell us a little bit about himself and about how he utilizes the MyoVision in his practice and in improving his PI. So tell us a little bit about yourself, Dr. Gregg.
Well, Dave, I've been in practice as a chiropractor for over 27 years in Phoenix and Scottsdale, Arizona. And I currently still practice part-time, and I also teach about 25 to 30 seminars every year all across the country on documentation. In addition, I consult with insurance companies and attorneys. I'm used as an expert oftentimes, a lot of times on defense cases where I review chiropractic records and I perform IMEs.
Okay, very cool. So do you find that you're doing a lot of more IME work now compared to the past, or is it pretty even? What percentage of your work is IME?
You know, I don't do that many IMEs, but I do a lot of record reviews. And in fact, the record reviews seems like it's been ramping up lately. In fact, I would say that from one company, I've probably done about 4 in the last 6 or 7 days, which was kind of crazy with that. But yeah. I just see this all the time. And to be honest with you, I see the same stuff over and over and over again. It gets kind of easy.
Which is why your course is so valuable, because the fact you actually can get people prepared for that.
It's actually kind of, it saddens me because the stuff that I'm getting these doctors on, I'm like, it would be so easy for them to correct this stuff, because I never say that the doctor didn't do a good job treating the patient or that the patient didn't get better. My job is to simply determine, was treatment reasonable and necessary based on the documentation that I'm reviewing.
Right.
And I typically cut off doctors after only 4 weeks of care, and it would be so easy if the doctor would just document the right things. I just did one yesterday that the doctor was using certain diagnoses that they're a fraud trigger on that, and I'm like, oh, wow. It just drives me crazy.
You know what's really interesting is that actually you're kind of like my accountant, and what I mean by that is I use my accountant because the fact he has experience working within the IRS. So in so many ways, your experience can be actually used to everybody's advantage, and that you understand the issues and the documentation needs of the doctor, and you can actually, because you work in both areas, you can actually help them to make sure that they don't run into problems. Does that make sense?
That's exactly right. In fact, even in my own cases, my personal injury cases, you know, I'm very careful that I simply want to know what the truth is. Is somebody truly and legitimately injured, or are they not? And I'm perfectly fine with if the person is not injured or not very injured. I'm perfectly fine with having a small PI case, if that's what the truth is.
Right. On
the other hand, if it comes that the patient has significant injuries, I'm okay with that also. I just want to know what the truth is so that I know what's really the appropriate kind of treatment and the appropriate amount of treatment. Now, I want to know precisely, or as close to possible, when should I stop? When have we had maximum improvement?
Right. Now, that takes us to the questions about the MyoVision. So does that help you with that determination? Does it help you objectively determine whether you have a good case or not, or how far you need to go with a patient?
You know what, Dave? Years ago when I started doing this, I'm usually a pretty skeptical guy by nature, and I really didn't know what it would do for me. Well, once I started seeing the information I was getting from it, it literally changed the way, and not only how I practice, but it changed the way I look at how people are injured. It's a completely different mindset for me. So, in fact, now I'm able to determine, I mean, there are some people, I'll be honest with you, whether it's my own patient or an IME that I do, you know, I'll look at the history, I'll look at the records, and I'm thinking to myself, yeah, this person's probably milking it a little bit, and I'm kind of suspicious about it. And then I do my exam, and the whole exam could be normal until I do the MyoVision, and then I'm like, oh, well, that's different. And it totally changed my mind. In fact, I remember years ago, I was asked to do an IME on a truck driver who had literally fallen off his semi-truck and hurt his back. And the insurance company contacted me to do an IME on the guy, and I did. And the whole way through, up until I did the MyoVision, the whole way through, I'm thinking to myself, I mean, there's nothing showing up. All the ortho neuro tests were normal, and I'm thinking, wow, this this guy just really doesn't want to work.
Right.
And then I did the dynamic EMG, and I found that for the guy's lower back, which was his complaint, when he was in forward flexion, when he was bent forward, his paraspinal muscles were so abnormal. They were just completely contracting, and they wouldn't let go. And it totally changed I was like, oh, well, that's unusual. And it totally changed my opinion. And I wrote in my opinion that not only does this guy have an injury, but I'm afraid he's got a disability. In fact, Mike, the insurance company wanted to know, as a truck driver, he was a long-haul truck driver, meaning about 11 hours a day. And they told me, it's all or nothing. Either he can drive 11 hours at a time or not. What is it? There's nothing in between. And I said, not. I said, he might be okay for 4 or 5 hours. But I'm concerned that because when he's sitting, his trunk is in a flex position. And my concern was because his foot would start to go numb, his right foot. I thought, I'm concerned at 5 hours into this, if he's having those issues, his right foot goes numb. And then I could picture like a Toyota Prius with the family of 4 stopped short in front of him. He can't feel his foot to stop in time, and we've got a disaster on our hands. And when I sent the report in, 6 weeks later, the insurance company called me back and said they wanted me to now treat the guy. I'm like, what do you mean treat the guy? I did the IME on him. Yeah, we know. We want you to treat him now. So if anything goes to trial, you're no longer the IME, you're the treating doctor. I'm like, and they said, we'll give you 6 months to treat. And I said, I don't want 6 months to treat. I'm going to treat him for 4 weeks, and then we're going to see if I'm getting anywhere. Because if I don't make any different changes with him after 4 weeks, I don't know that I'm going to be able to do anything with him.
Got it. So when you use the MyoVision, you use the dynamic EMG range of motion combination.
Right.
And so you've used the old system before and the new one, which is the combination of the two. I know that you've said that you find it more valuable. Does it help you significantly more than just the EMG on its own? Or
yeah, exactly. It does, because it helps me determine if the patient was legitimate about their range of motion. In other words, if somebody shows a limited range of motion, but their muscle activity from the EMG at that exact moment in time, so there's limited motion, but the EMG is abnormal, that tells me that there's a physiological reason for that limitation.
Right.
But every now and then I'll see, like in the IME sometimes, I'll see somebody that the limited range of motion, and they're moaning and groaning about it. And then I do the EMG and it's completely normal. And that tells me that the patient stopped voluntarily. Their physiology did not stop them. And that is an eyebrow raiser for me.
That's good. So, I mean, it's I don't know why it's so hard for people to want to use objective data to make decisions, but it's obviously it's an important thing. Also, it sounds like you've used this, both as an IME, but also you've used it on the plaintiff side too. Is that correct?
Right. I mean, I'll have, both on my own patients who've been auto accidents, as well as every now and then I'll have an attorney, a plaintiff attorney, send me their client who's been to other doctors and chiropractors for treatment, and the patient is still having problems. So here's an example for you. A plaintiff attorney got a hold of one of my reports, because I do these exams for other doctors.
Right.
So he got a hold of one of my reports. I'd never met this attorney before. And the attorney called me and said, hey, this is great. I have an issue. He says, I have a husband and wife who were in an accident about a year ago. And I'm getting ready to give a demand to settle this case. The problem, he said, was the husband and the wife think their case is worth this much, and I think it's worth this much. And they won't listen to me. And he said, so honestly, I would like you to do this exam on my clients and let me know objectively, look, he said, Greg, if you tell me that, no, these people they've got injury with that, I will admit my error and I will adjust my demand accordingly. But if you say that they're not objectively injured, then I could present them with that to say, look, here's an independent guy. So I said, well, that's an interesting take. So he paid me to do this. I saw both the husband and the wife, and their symptoms were quite high. I mean, this is like a year after the accident. All their symptoms were like a 7 to an 8 out of 10, which is a little eyebrow raising for me. I'm checking all these other things, ortho, neuro, everything. Range of motion was normal. I did the dynamic EMG, And you know what? It was almost completely normal. Now, both of these people are in their 60s, so I'm okay to see a little bit of abnormality just from age. And I saw a little bit of abnormality, but most of the test was completely normal. Right. And I told the attorney, I said, you know what? There's some stuff, but most of it's normal. So here's what I would do. I would be comfortable saying that there's some minor injury going on there, and I'd be okay to recommend, let's say, 4 more weeks of treatment, not chiropractic treatment because they've already been through that and they've gotten as far as they can go, but any kind of treatment, give them maybe 4 weeks. I want to remeasure them after 4 weeks of treatment to see, did it change significantly? Right. And if it got measurably better after another 4 weeks of treatment, then I would say, all right, keep treating another 4 weeks, keep going. But if it didn't show measurable improvement, then I would say, done. Mm-hmm. And he was like, beautiful, that's what I need. I went ahead and got some projected cost of treatment for him, wrote that in a narrative for him, sent it away, and he was able to then present that to his clients and then get a demand that they both felt comfortable with. Right. I mean, it was a completely different way that I've seen the plaintiff attorney use that.
Right. And one of the things I've been seeing is I've seen a lot of attorneys saying what they love about the MyoVision, the Dynaram stuff, is the fact that they know if they have a good case up front or not. Like they know when to put the energy in. Are you seeing that also? Are you seeing attorneys? How are attorneys responding to this?
You know, I've met with attorneys and I told them, I said, look, it is in your best interest as a plaintiff attorney to know if you've got a low case or a high case, because they don't want to be putting all kinds of time and energy and even money into a case only to find out later that that was a whole bunch of nothing. Right. I said, I'm able to determine very quickly early on, you know what, this is a nothing case. We're only going to treat this patient, I'm thinking maybe 4 to 8 weeks tops on this. Don't put a lot of energy into it. On the other hand, I'll have a case where I'm like, okay, you've got all kinds of objective data here, and then we've got ligament damage on top of it. I mean, there's going to be I hope there's high policy limits. They love knowing that, okay, great, I know where I am at the beginning of the case, not just at the very end, because at the end, it may be too late for them. They've already accepted. I can tell an attorney whether they should take the case or not. Mm-hmm. With that, just on the kind of data, I'm like, yeah, not a lot of stuff here. Not a good case for the attorney.
So you're bringing up a good point. Is it actually helped your confidence in terms of interacting with attorneys to actually have this data?
Absolutely. I'm able to meet with these attorneys. I love it when they come. You know, they'll request meetings with me, and I'll tell them, I said, this is what this shows me, and I will not fudge on a case. Right. Look, if somebody is not injured or they're only injured a little bit, that's what it is. I'm not going to lie about it. But if somebody is significantly injured, and I'm going to reevaluate every couple of weeks and see, are we getting anywhere? Are we improving? Or do I need to change something about the treatment? For example, I have a patient right now who's in an accident, and the only thing going on in his cervical spine for the dynamic EMG are in the SCM muscles. The paraspinals are fine. It's only SCM muscles where it's going into flexion and extension, like that. So in addition to my adjustments of him, I'm also using low-level laser therapy. While he's doing exercises, I've got the lasers on his SCM muscles, and I have him going into flexion and extension. Wow. And so I'm tailoring my treatment to what I'm getting from the data that I get from this type of a test. In addition, in my documentation, I can set specific goals not only for improving range of motion by this many degrees, but I'm so anal about this, Dave, that my goals will be to improve sternocleidomastoid function on the right side during flexion and extension of a cervical spine. That's how specific I can get with it.
That's great.
So it's great.
That's cool. So you're actually using it to help determine what's the appropriate treatment and as an outcome measure too, in addition.
Not only what is the appropriate treatment, but is that treatment even working or not? And if it is, great, keep going until it's normal. And if it's not, then change something. Right. And then I'll keep treating the patient until we get them to a spot where they're either normal, everything's normal, or it's just not changing at a certain point. Right. And then before releasing the patient, I will do what's called a withdrawal from care. All right, I want to see you back in 2 weeks without any treatment unless there's a flare-up. And they come back in 2 weeks and I test them again and see if there's any measurable change. And if they're doing well then, I'll say, let's go another 4 weeks out with no treatment. And then we measure again. And that way we can see, all right, we're pretty good at in those 4 to 6 weeks, they've been increasing their activity levels, so I want to know that they can do things on their own without me, without jacking themselves up all over again. So the information that I get is so critical for determining if my treatment is effective or not, when to stop treating, when to continue treating, when I've gotten as far as I can go, and maybe I need to send out for some other kind of treatment.
Got it. So it sounds like what you're doing is pretty complicated. Do you find that it slows you up too much? Is there any issues with time as far as how long it takes to perform this exam? I know that I went on my way to make it as simple as possible, but practically speaking, is it difficult for you to use, or do you find it really simple, or what would you tell people about it that way?
It's very easy. When I learned how to do it, I spent an hour looking through the manual and the videos of you showing me how to do it. And then I just started doing it on some people. And I got to a point now where I could do, if it's cervical spine, I could do really the longest part of the test is just getting electrodes on there, which only takes a minute or two.
Yeah.
After that, it's however long it takes me to do the test, which could be just a couple of minutes. So I'm thinking average of 5 minutes or so for one area. And if I'm doing both cervical and lumbar, it may take me about 7 minutes or so to do that. And even though I may do 3 tests on somebody, if I see after 2 tests it's perfectly normal, I'll just move on to the next test. I'm only going 3. Sometimes I'll do 4 or 5 tests, because sometimes I'll see it's normal at the beginning, and then every time they do it afterwards, it's getting progressively more abnormal.
Right.
So I'll kind of watch them do that for a while, because I'm looking for, I'm not looking for, oh look, there's an abnormal one. I'm looking for a pattern. I want to see, okay, they need to get used to it for a little bit, and now their muscles are kind of getting in the groove like that.
Right, and that happens. People that's a common thing to see, is people that are that have injury, they get worse the number of trials you perform, which is what you're talking about, how many trials you do of each motion.
Right.
And those that actually aren't, they get better over that same period of time. So that's great to hear. What I think is really funny was I remember this happened, the first test you did was, what did it happen? It led to like a PI award that was beyond what you'd seen.
It was an IME.
And you didn't believe this thing actually had the ability to do anything.
Yeah. I was asked to do an IME for a plaintiff attorney, and his client was in an accident like 3 years prior, and the insurance was offering nothing on this whole thing. Right. So my IME, I spend about an hour and a half. It's not a 5-minute. So I do the ortho neuro exam. Everything that I did was totally normal on this guy, and I was like, wow, that sucks, because I really believe that the guy had a problem. I just couldn't prove it. Right. So I was going to have to call this lawyer and say, sorry, I got nothing for you. I'm literally walking the guy out to the door of my office, and I thought, I was standing and I saw out of the corner of my eye the equipment in my exam room, and I thought, I wonder if that would show anything. Yeah. So I said, what, come back in for a second. I want to do one more test on you. Look, the worst that could happen is I get a little bit more practice time on it, because I hadn't used it for a couple of weeks, because I didn't know what I was going to do with it yet. Yeah. So he comes back in. His issue, he had a thoracic spinous process fracture, about T7. Well, I didn't want to do it on this thoracic spine, because there's not enough motion in there to really show anything. So I thought, well, I think I'll do it on his lumbar spine, because, well, it's not cervical. So it must be lumbar. Right. So I did his lumbar spine. I did the test. I wasn't even sure if I was doing it right. And after the test was done, and after he left my office, I called you, and I'm like, okay, now what do I do? So you had me fax you the graphs, and then I called you back, and you walked me through the interpretation, because I didn't even know how to do interpretation yet. Right. And I'll never forget, you said, I didn't tell you anything about this case, and you said, this is a chronic injury. And I said, well, how could you possibly know that? And you explained how the graph lines in an acute injury, they're oftentimes very bouncy and jittery from fasciculation. But when it's chronic, the muscles acclimate or habituate to the injury, and they become very smooth. Well, this was all very, very smooth. And you said, this is probably a chronic injury. Am I right? And I said, yes, it's 3 years old. Right. But see, what that did for me was I immediately thought, what if I was able to get an injured person in my office within the very acute stage, meaning the first couple of days of an injury, right? And I do this test, and the muscles are all jumpy and fasciculating like that. Can I now say objectively that this is most likely an acute injury because of that? Absolutely. Right. On the same token, what if that in the first 2 days of acute injury, All the lines are nice and smooth. Does that also tell me that, you know, this could have been pre-existing?
Right.
That to me, again, I don't care what the truth is. I just want the truth. That was so powerful. Well, I talked to you on the phone, and I remember asking you, because you kept talking about, well, there was muscle bracing in these positions. And I said, Dave, when you say muscle bracing, is that the same as muscle guarding? And you said, yeah, same thing. And I said, well, I'm going to use the words muscle guarding then. And you said, why? And I said, because in the AMA guides to the evaluation of permanent impairment, 5th edition, DRE, diagnosis related estimate, category 2, which is a 5 to 8% whole person impairment, says, and I quote, muscle guarding or spasm observed at the time of the exam, end quote. And I was like, I got all I need. So I ended up writing a 7-page report for the attorney. I bumped the guy's impairment from 7% to 14%. They went to a mediation, and they went from having an offer of 0 to getting an award of $150,000. Now that $150,000 was actually originally, it was between $250,000 and $300,000. The $150,000 is that after they reduced it to $150,000 because he wasn't wearing a seatbelt.
Wow. Okay, so that's pretty amazing. And that was I remember how shocking that was to you too.
First time, I couldn't believe it.
First test, and it's happened to a lot of people. It's funny how many people call me with these kind of stories. Their first test was magical for some reason, and you expected that to pay out maybe 15,000 or 10,000 or something.
I thought it would be about 10,000.
Right, and you found it later on. So, anyways, we're running out of time, but it's been really great to talk to you about this stuff. And do you have any recommendations? One of the things that you brought up that I think is really critical, I want you to re-emphasize, is like what the doctors should be doing from your perspective. Is you're really working, doing both sides of this. You're looking for the truth, really, which is what everybody should be doing. What would you recommend for the doctors out there? Besides, also going to your course is really great. I mean, I know everybody loves that. So it's truly, I mean, it's really an important thing, especially these days. But what would you recommend as far as instrumentation goes? Has it been...
Well, the first thing is we've got to get as much information, pertinent information as we can. So it starts with the history. So we've got to get as much history information from the patient at the very, very beginning, and then establish some kind of measurable baselines. That is so critical, because this is why I end up cutting off most chiropractors after only 4 weeks of treatment, because they don't show any measurable baselines, they don't show any measurable improvement, and these are the standards now. It started with Medicare. Medicare requires this, and so does everybody else. Right. So you've got to, so outcome questionnaires, the range of motion measurements, dynamic EMG, I establish where are they now. Maybe there's ligament damage I'll get from flexion extension x-rays, I'll get all that information, and then I'll start determining, okay, where are they in the realm of injury? Right. And then we start treating, and then every 2 weeks, every 2 to 4 weeks, for me I do every 2 weeks, I will do a reevaluation, which will include outcome questionnaires and the range of motion, dynamic EMG, only because I want to see, is the treatment that I'm doing effective or not? Do I continue on that, or do I change something, or is the patient at maximum medical improvement and do we stop? And that's it. And I document my daily notes very specifically so that you can see my goals of treatment, you can see when my reevaluations will be, what I'm going to be doing, when the patient reaches these goals, when the condition resolves. It's so easy to do this if doctors just understand it, but we need the information, and that's why the dynamic EMG that I do with the range of motion is so critical. Dave, I'm telling you, literally not only changed the way I practice, but it changed the way that I look at injured people. It would be very difficult for me to practice without it at this point.
Right, yeah, I understand. All right, well, great. Well, thank you so much for being on today from beautiful Phoenix, where I understand it's 130 degrees today, right? Obviously, we're shooting inside for a reason, right?
That's right.
So thanks a lot, Dr. Gregg. And yeah, but what's your website if they want to go to your website for information?
It's www.gotdocumentation.com. So GOT, G like George, O, T like Thomas, and then we're documentation.com.
Great. Thank you, Dr. Friedman.
My pleasure. Thank you, David.
Yeah, bye-bye.